Neurogenic back pain. It is important to remember that lower back pain can be caused by pathology in different organ systems or a combination of pathologies. The most notable systems involved in lower back pain are the musculoskeletal and neurological. McNabb's classification of backache gives us an approach to finding the underlying cause of backache. These classes are viscerogenic pain, which is referred to the spine for abdominal and pelvic viscera, vasculogenic, spondylogenic due to skeletal pathology, psychogenic, and neurogenic, which is the focus of this presentation. These are the red flags for back pain. Any of these red flags makes a diagnosis of degenerative causes less likely, and prompt investigation for the cause is appropriate. As you can see, neurogenic backache is important because it is one of the red flags. As you can see, widespread neurological signs and symptoms is a red flag and warrants further investigation.
In order to localize the origin of lower back pain, it is important to understand some anatomy. The spinal column consists of 33 paired vertebrae which are separated by discs. The most important job of the vertebral column is to protect the spinal cord. The transverse foramina allow the nerve roots to travel to where they need to be to work.
Reticulopathy is the impairment of a nerve root, usually causing radiating pain, numbness, tingling, or muscle weakness corresponding to a specific nerve root level. Sciatica is when the symptoms follow the distribution of the sciatic nerve radiating down the posterior or lateral aspect of the leg, usually to the ankle or foot. Cauda-equina syndrome is the loss of bowel and bladder control and numbness in the groin associated with weakness of the lower extremities. It can be caused by abnormal pressure on the bottommost portion of the spinal canal and spinal nerve roots.
The most common cause of neurogenic back pain is a herniated disc causing increased pressure on one or more of the nerve roots. And depending on its location, the patient presents with specific signs and symptoms. The material protrudes posteriorly into the spinal canal, which migrates freely up and down the canal into the root foramina. So what causes the disc to herniate? It may start after acute injury, such as lifting a heavy box. It may also be aggravated by anything causing increased intrathecal pressure, like coughing. Paresthesia is also suggestive of a disc herniation. Activity may ease the pain and rest does not.
Don't be fooled. Always ask about preceding back pain in a patient with leg pain. The distribution of dermatomes help to aid in localizing the pathology. As with all other musculoskeletal examinations, we need to inspect, palpate, move, and perform special tests to aid in the diagnosis.
At the Orthopedic Spinal Clinic, you are relieved to see only 4 male patients in the waiting area. However, they are all presenting with symptoms of neurogenic backache. This would confuse any medical student, but are you able to determine the level of reticulopathy clinically?
First up is Marlon. As he walks over to you, you notice that he is not extending the knee. He complains of back pain. On examination, you find that he also has sensory loss in his medial calf and loss of his knee reflex. You perform the special femoral stretch test, and what you know, it's positive. Diagnosis: compression of the L4 nerve root. Demonstration of a positive femoral stretch test. It starts with the patient lying prone. The examiner passively flexes the knee towards the buttock and extends the hip. The patient experiences pain in the anterior thigh region.
The second patient, Nathan, appears to have a foot rub. He also has sensory loss on the lateral calf and dorsal first web space, as well as a loss of medial hamstring jerk reflex, and on examination, a positive straight leg test. The diagnosis is compression of the L5 nerve. The straight leg raise test is used to evaluate for lumbar nerve root impingement or irritation. This is a passive test with the patient lying supine. The knee is extended and the hip is flexed until a complaint of pain or tightness is reached.
Third is Matt. He appears to be walking abnormally. He is unable to plant or flex his foot. He has sensory loss on the lateral border of the foot below the lateral malleolus and an absent ankle jerk reflex, as well as a positive straight leg test. The diagnosis is compression of the S1 nerve root.
Lastly, you see Claude. He is a 25-year-old jockey training for the JMB Met. He presents with bladder and bowel paralysis and on examination has a positive straight leg raise test as well as numbness in the groin. The diagnosis is that of cauda equina syndrome.
The ESR helps to rule out active disease process associated with systemic effects. X-rays allow us to see bony problems clearly. Soft tissues such as discs are not seen clearly on X-ray. It will only show the space a disc occupies, which could only suggest disc problems if the space is narrower than expected. It will not show pathology. Lumbar spine MRI scans. Unlike X-ray, this test gives a clear idea of soft tissue structures such as discs, ligaments, the spinal cord, and nerve roots.
The majority of patients will have spontaneous resolve. However, you should refer immediately if there is bladder or bowel dysfunction, marked muscle weakness, or progressive neurological deterioration. Rest and analgesia are prescribed. If the above fails, surgical decompression is considered with post-op physio for regaining strength and function.